If you have a health insurance plan through an employer, but you can't afford it, can you opt out and get insurance through this marketplace, this exchange? Who wants to handle that? Kristen?
I'm happy to take that.
Thank you.
So people who have access to coverage from an employer that meets two key criteria. If you have coverage from your employer that meets two criteria, then you can't get a tax credit in the exchange, in the marketplace, to buy marketplace coverage. And those two criteria are: is the coverage affordable, and does the coverage meet minimum value? Affordable means that it costs less than 9.5% of your income for your household, and so most employer-based plans are going to meet the test for affordability, but not all. So if it costs more than 9.5% of your income, then it's not affordable, and you can come get a tax credit in the marketplace. The second test is something called minimum value. It's a measurement of how generous the insurance plan is. And your employer needs to tell you whether or not your plan meets minimum value. And they're required to tell you that information. And if it doesn't meet minimum value, then you can get a tax credit. But if it does meet minimum value and it is considered affordable, then you can't get a tax credit in the marketplace. Now, anybody can shop in the marketplace. If you just want to turn down your employer coverage and come to the marketplace and shop for a plan for whatever reason, you're welcome to do that. But you won't be able to get a tax credit if your employer coverage meets the test for affordability and for minimum value.
Very good. So you got that. If you're paying more than 9.5% of your income, then you can go in the marketplace. And if your employer doesn't offer an adequate plan, and there are a number of criteria, then you can go in the marketplace. Otherwise, of course, you can go in, but you don't get the tax credits, and so you don't get the financial benefit of it. Well done. Thank you. Now, here's the person, maintains residency in Virginia, but spends 4 to 5 months every year out of the state for work. Will the plans from the marketplace follow them when they're out of state?
So I guess I can take this one too. So there will be an option in some states.
Keep the microphone close to you, Kristen.
There'll be an option in some states for something called a multi-state plan. In multi-state plans, we don't know much about them yet. They're operated by the Office of Personnel Management, and they're going to develop over time. And so a multi-state plan might help someone in that situation, or it might not. So that might be an option for somebody like that to consider. In general, most plans in the marketplace are going to have a network of providers that are based in Northern Virginia, and getting coverage if you're visiting your kids in Florida for a few months, it's going to be considered out of network and will have much steeper cost sharing. But if you need to go to the emergency room while you're in Florida, that will certainly be covered under your plan. But in general, you're not going to have the same kind of coverage for routine primary care when you're away from your home service area. But the multi-state plan would be something for somebody in that situation to explore.
So it's pretty much the way it works currently for private health insurance.
Exactly. It's exactly like today's health insurance market.
Doug.
One thing you might want to do is look carefully at the plan design of the plan you choose. An HMO, a health maintenance organization, is a regulatory structure that tends to rely on a more limited service area. A PPO, a preferred provider organization, tends to have a more open network. There may be PPOs available for you to buy. They may be more expensive, but they also might fit your needs better, and that's why you might choose them. It just depends on the design of the product. So I would look real carefully at those and ask good questions.
Very good. Here's one. Will there be a federal exchange available? The answer is yes, and that's all you will have, whereas in a state like Maryland, for example, who wanted the Affordable Care Act as opposed to the governor and majority of the legislature who didn't want it, there will only be this federal exchange. The federal government will run it. In Maryland, for example, the state will run it and is investing more in it, so it will be somewhat more accessible and affordable. But you still will have a federal exchange in Virginia. You want to add to that, anybody? Okay.
I think you covered it. Healthcare.gov.
Healthcare.gov. Do they have to use the capital C in healthcare?
They do not.
Okay.
Works so either way.
Okay, because that was capital H and capital C. Healthcare.gov. Here, if I'm a contractor who works for several different companies. Some provide insurance, some don't. When I'm between jobs, what do I do for insurance? And if I don't get Affordable Care Act insurance, will I be fined?
It's a great question. So we've talked a lot about the open enrollment period, that first period where you have to enroll, which runs from October 1st to March 31st. And that's when most people who sort of are currently out there today need to come in that window from October 1st to March 31st. But people who have changes in circumstances in their life can qualify for a special enrollment period. And one of those special enrollment periods is losing employer-based coverage. So if I'm working right now in a job and I have coverage from my employer, and I have that job until the middle of April, and then I change employers and I lose the work-based coverage that I have, that triggers a special enrollment period, and that gives me an opportunity to come into the marketplace and enroll in coverage and pick a new plan. And similarly, if I then, say at the end of the year, get another job that has health insurance again, that also triggers an opportunity for me to drop my marketplace coverage and go to my employer plan. So people who have those changes in circumstances throughout the year outside of the open enrollment period get a special enrollment period to enroll in coverage. To answer the question about the fee, as many of you know, the Affordable Care Act does require people who have access to affordable coverage but don't take that coverage to pay a penalty. It excludes people with short coverage gaps of less than 3 months. So if you have a short gap in coverage during the year that's less than 3 months where you're without coverage, as you're moving between these different options, then you won't pay a penalty. But for people with a gap in coverage that exceeds 3 months and that had access to affordable coverage, either from the marketplace or from their employer, they will owe a penalty for the period of the year that they're without coverage.
Good for you, Kristen. Thank you. You know your stuff.
Hey, Jim.
Yeah, Doug.
One of the nice things about the law is that if you're an independent contractor and you're stringing together many different contracts, you don't really get offered any benefits. And so what you're really trying to figure out is what your expected income is for the year. And so what you would do when you're applying is you would make a prediction of your income for the year, and that's how you could determine whether you get a subsidy or not. And there will be a squaring of the account, for lack of a better term.
You can't lowball your income to get
right.
the
So
subsidy.
in other words, if you make more than you thought you were going to make, they're going to ask for take some back, and this very well might happen through your taxes. So you know it's in your best interest to make a fair prediction based on knowledge, and then of course the federal hub will also have some background, and that will kind of help people kind of get some parameters around whether you're in the right ballpark, for lack of a better term. But the bottom line is contractors really had a tough time before this law, because the reality is they might have been able to afford it next year if they had some good contracts this year. This is going to make it possible for them to get coverage consistently all the way through. They will still have to square in the end, but it will probably help them. A great example would be realtors. A lot of realtors have good years and bad years, and when they don't have a good year, they don't have the money to do these sorts of things like get health insurance.
But now they will. That's a very important point. Thank you, Doug. So, a whole lot of people whose incomes keep going up and down, and sometimes they have insurance, sometimes they can't afford it. Now it's far more likely they'll be able to consistently have insurance available throughout their employment. Here's a good one. Does COBRA still exist after the Affordable Care Act?
Someone else want to take that? I can.
Go for it.
COBRA continues to exist. So employers, if you have coverage from an employer and you lose that coverage because you leave the job, your employer is required to offer you COBRA, where you continue to pay to stay in the same plan, but you pay the full premium. Most people will find that they can get a better deal in the marketplace. And so COBRA can be really expensive for a lot of families, and I think most people will find that they're better off going to the marketplace, taking advantage of that special enrollment opportunity that I talked about, and going to the marketplace and getting that plan rather than staying in COBRA. But COBRA definitely is there and remains an option for people for whom that makes sense.
These are excellent answers. Can everyone hear me in the, for example, in the back row? You can hear okay? Okay, good. As a small nonprofit agency, under 20 employees, what information are we required to provide our employees about the Affordable Care Act?
Sure. So this is a question about something called the Fair Labor Standards Act 18B notice. So remember, when people go to the exchange, the marketplace, to apply for coverage, they need to say whether or not they have affordable minimum value coverage from their employer. The employer has to tell them that so that they know whether or not they qualify for tax credits in the marketplace. And so under the Affordable Care Act, the vast majority of employers are required to provide a notice to their employees that lets them know whether or not the coverage the employer offers meets that minimum value test. Or alternatively, that just says we don't offer coverage at all. And that notice is supposed to be received by employees by October 1st for all your current employees, and then every time you hire somebody new, you need to provide them with that notice as well, again, so that they have the information they need to go into the marketplace and apply for coverage. So the Department of Labor has published 2 sample notices that employers can use, one for employers that provide coverage, where they can sort of fill out some information about the coverage they provide, and another for employers that don't provide coverage, that simply says, I'm your employer, I don't provide coverage, you can go to the marketplace to shop for coverage. But companies don't, or employers don't have to use those templates. They can use a different form if they like. I'm happy to somebody can follow up with one of the congressman's staff, and I can send you the link to the technical notice that explains what you need to do and shows you those sample forms that you can fill out and give to your employees. And
I assume that small nonprofits, as small for-profit businesses, would call the shop call center.
Absolutely. So just like there's a marketplace for individuals, which is what we've been talking about all night, there's also a similar marketplace called Shop for small businesses. And a small business that wants to provide coverage can go to the shop and offer coverage, and that's the phone number to call to get started in that process. Healthcare.gov has information too.
Yes.
Also, just want to know that for small business owners, navigators can also help, not just with families and individuals, but we can also help small business owners as well.
Okay, so you got that. So it's not just individuals and the members of their families. Businesses can also take advantage of the navigator service. Here's a good question. Can you tell me how the Affordable Care Act will cover preventive services, such as birth control and immunizations? Sarah Waskowicz asked this. She used to be an intern. She's here. What about preventive services?
Yeah, they're covered. The bottom line is that there's a list, and the list lists all the items that are covered. The one wrinkle is that when a provider gets you in their office, sometimes they might decide that there are other things they'd like to do that are not preventative services, and then the copays and cost sharing will show up. So one of the challenges for people is to make sure that you try to keep the two separate. And there have been some studies done that show that as the preventative service requirement went into effect, and it's been in effect for a while now, this is not something new, that what happened was other things started to happen during the visit, and that created some friction and frustration. Certainly created a number of calls to the health plan. Yeah. What are you doing to me? And of course, it really wasn't us. We were following the law. It was what happened during the visit. So you do have to be an educated consumer when you go out to use health care.
Doug makes a very good point. You know, when we passed the Affordable Care Act, that's one of the things that was implemented almost immediately to cover preventive care. But when you go and get that preventive service, it's entirely possible, probably likely, that many providers will then provide other services which are not covered as preventive care, and you wind up getting a bill for those. So just be on the lookout and ask questions. Now, as a senior who is retired but working 3 days a week, and a candidate for knee replacement, will it be allowed and approved for the procedures? Just, yeah, okay.
Are we assuming the seniors on Medicare?
I think so.
Nothing changes there. It's a covered benefit. If your doctor says you need it, you get it. If you don't have a Medicare supplement plan, you may have some out-of-pocket costs. Sure. There's a hospital deductible if you have to get it inpatient, but that's things that are already in place. If there's a good medical reason that you need a knee replacement, your doctor wants to do it, nothing has changed, you can still get that.
Very good.
In regard
Yeah.
in regard to the exchange, it's going to be just a normal insurance product, so you would have cost sharing, but it would be a covered event. One thing that I think people will spend some more time talking about as we get through enrollment, I think the navigators will talk a lot about this, is what plan you choose is important depending on your own personal circumstances. So if you're going to use health care a lot, you might not want to choose a bronze plan because you're going to have a lot of cost sharing to pay as you use those services. You might want to use a richer plan, something more like a silver or gold plan, but it depends on your circumstances. And so it isn't always the best choice to pick the lowest metal level. And that's something that people will have to learn over time and kind of work their way through. It's not always intuitive. You're going through the process and you sort of say, well, yeah, I should pick the cheapest one. Not necessarily.
And these metal levels, just to reiterate, that's the choice about whether you want to have low premiums and
Right.
higher cost sharing or higher premiums and lower cost sharing. And there's four different levels: bronze, silver, gold, and platinum. And so you choose where on this continuum you want to be in those 4 levels. So when we talk about a bronze plan, we're talking about one of these plans down here that has the lowest premiums but the highest cost sharing. But people have the option to buy up to higher levels.
Right. And you're not likely to see a platinum in the exchange. You'll likely see bronze, silver, and gold.
And
Yeah.
part of what we'll be doing as navigators is somebody can come into our office and there are a lot of tools on the website that we can walk them through and they can compare the plans based on their personal needs. So even within those different metal levels, there may be a lot of different plan options for any particular person.
Very good. I think Maryland does have a platinum plan, don't they? The highest level.
They might.
Yeah.
I was just referring to
Yeah, no, it's a very good point to make. For example, if you're young and healthy and you don't have a whole lot of money, there will be a plan that will be very cheap for you. It's basically catastrophic care. So you figure, I'm not going to go to the hospital or the doctor unless something really bad happens. I don't need to. Very different situation than if you're older or sick or whatever. And so you may pay 50 to 100 bucks a month at the most. Then if you get in an accident or something, then the catastrophic care kicks in. Otherwise, it's going to be pretty cheap for you. But that money and that inclusion of young people, particularly, who are not getting insurance now, that needs to be part of the pool so as to offset the higher risk of people who are older, who are much more likely to need health care. But one of the things the Affordable Care Act did was to say that you can't charge somebody any more than twice what you charge younger people just because of their age. It's twice, isn't it?
3 times.
3 times, 3 times. You can't charge 3 times. Many plans were charging 6 and 7 times greater for an elderly person than for a young person. Now, that was based on actuarial tables that showed that elderly people are that much more likely to use health care. But the Affordable Care Act built in a bias to keep health care more affordable for older folk by limiting it to no more than 3 times, which is a much lower percentage in terms of the cost to the insurer. So that's a built-in subsidy for seniors and people who are disabled or whatever as well. So,
If I may, Congressman?
Yeah.
You know, AARP represents people 50 and older, so a lot of people who are not eligible for Medicare yet. That particular provision, that limitation on how high premiums they can charge, really makes private insurance a better bridge to Medicare for people.
That's a very
older
good
age
point.
groups.
Very good point. So before you're eligible for Medicare, but you're still over 50 years of age, for example, or you may have retired, or you may have been, you know, pushed out or whatever, bought out, that gap is very serious. But this gives you that cap on the cost that what health insurers can provide. So Doug makes a very good point. That's one of the biggest benefits of the Affordable Care Act for seniors, doesn't get much notice, and it is a very costly provision to insurers and the government, but it's an important one to be aware of. People who don't know that or don't take advantage of it are really missing the point of this bill. Okay, now, can we apply for Medicare Advantage programs on the same application? My husband is in a Humana Medicare Advantage program. Will that program change? Medicare Advantage.
Nothing changes on Medicare Advantage, no. Just you apply for it just like you do now, if you're already in it and you like what you've got, you can just stay with it. The open enrollment period is coming up. I might have misstated the dates a little bit before. It's October 15th to December 7th, but nothing really changes for Medicare Advantage, and you do not go through the exchanges to get it. It's just the current system. If you want to compare plans, Medicare.gov on the website can lead you to the Northern Virginia area and show you what Medicare Advantage plans are possible. And I suppose your office also has such information at the Wisconsin Association of Health Plans.
Yeah.
Yeah.
And so just to be clear, a family where one person is in Medicare and another person is going to be shopping in the marketplace for a qualified health plan, they would fill out two separate applications. So the person who's in Medicare would go to Medicare.gov and go through the Medicare process, and the person who's in the marketplace would go to Healthcare.gov and fill out a separate application. They're separate. They're separate applications, separate programs, and nothing about Medicare is changing.
Thanks, Kristen. Again, these are very important, and of course, as Patrick had mentioned, he said December 15th. I think you meant to say December 7th, right? Isn't that the date? I think
October 15th to
October
December
15th to December 7th.
It's December 7th. So if you don't sign up by December 7th, then you don't get that insurance that would otherwise be available as of January 1st. Huh?
That's the Medicare period.
Yeah.
So Medicare's open enrollment period, it's on an annual cycle. It's every year, October 15th to December 7th. For the marketplace, the open enrollment period runs from October 1st to March 31st, and you need to sign up and pay your premium by December 15th.
Okay.
If
it's
you,
December 15th for the health exchange, it's December 7th for Medicare.
Exactly.
Okay. If I work in the district, I'm self-employed, can I then choose from plans offered within the district? And would my family members qualify to enroll as well in the district, assuming you actually live in Virginia?
If you live in Virginia, you'll use the Virginia marketplace. It's based on where you live, not where you work, for an individual applying for coverage for them and their family. Yep. So it'll be the Virginia marketplace, not DC.
Thank you. What measures are you taking to ensure privacy of personal information from identity theft?
It's another one for me, I guess.
I just wanted to say that part of our training was about security, and to make sure that we're navigators and other people that are working should not take your information. They should not make copies of your information and say they're going to hold it for you. Then you're not dealing with someone who's part of the Affordable Care Act. We will not hold your information for you. We'll help you make copies and help you fill it out. But I just want to make that clear for if you're working with someone who's not a navigator and they say, give me all this information, they should not be doing that.
So we take protecting individuals' personally identifiable information incredibly seriously. We have a fact sheet for consumers that we'll make sure the Congressman's office has that gives people some tips to protect themselves from fraud. Things like nobody should be asking you to make copies of your information. Nobody should be asking you for your personal health information. There's no health information on the application. People shouldn't be asking you health questions as you go through the application process. Nobody who's involved in the application process has access to a database of personally identifiable information. When you sit down with a navigator to get assistance, they're going to work with you at a computer. They might help you figure out what information to put into the application, how to figure out what some of the questions mean. But then you press send on that application and the navigator no longer has access to it. So there's no database of personally identifiable information that anybody has access to, but we are incredibly committed to protecting people's information. If you have any concerns about how your personal information is being used, you can call the call center, 800-318-2596, and we'll follow up on those complaints. And we're working closely with our partners at law enforcement agencies and other federal agencies to really make sure that anybody who tries to abuse the Affordable Care Act as an opportunity to steal personally identifiable information, we have zero tolerance for that kind of activity, and we'll be going after anybody who really tries to take advantage of this opportunity.
The next question is on the IPAB. This is an advisory board that we set up as part of the law to share best practices. In other words, what practices on the part of healthcare providers are the most effective, efficient, what achieves the best results? And we wanted to set some standards. Well, it has become very politicized, and we've been lobbied heavily, and there hasn't been a whole lot of support just because the Congress is so weak on some of these issues, frankly, and afraid to say no to anybody. And if any of you have read some of the articles, the Time magazine articles, so many articles, whether it be in the New York Times, Washington Post, the healthcare providers charge enormously different prices dependent upon where you are and who the provider is. And frankly, a lot of people get ripped off by excessive charges, and they don't get any better care, sometimes worse care. So the system gets gamed, and we were trying to set some best care practice standards, and we haven't been very successful. But tell us where we are on that, Kristen.
Sure. So as the Congressman mentioned, the IPAB, the Independent Payment Advisory Board, was set up by the law to make recommendations for making some tweaks to the way Medicare pays providers if Medicare costs are growing quickly. The idea of these tweaks is to really focus on places where there's waste and abuse in the system, where we're spending too much money and not getting a quality benefit. The use of the IPAB is pegged to how quickly healthcare costs are growing. So the IPAB is only something that we're even going to start thinking about when healthcare costs are growing faster than a specified percentage. Luckily, we have seen 3 years in a row of the lowest sustained healthcare cost growth in history. For the last 3 years, healthcare costs have been growing more slowly than at any time since we started measuring healthcare costs. We've seen there's a lot of reasons for this, but we are really encouraged by this trend, and healthcare cost growth has really slowed over the last couple of years. And as a result of that, the IPAB isn't going to be triggered for many years into the future. As far as sort of we're making predictions, there's no reason for the IPAB to come into play because healthcare cost growth is largely under control right now.
Thank you. Well done. Yeah, Doug.
Let me give you a little bit broader thought. We're spending 18% of GDP on healthcare. We pay larger cost per unit than anybody. The bottom line is we're going to have to pay less per unit, and we're going to have to buy less units. That's just a fact. How we get there needs to be in a quality way. So when unnecessary services are offered or ineffective services are offered, we're going to need to figure out how to identify those. Insurers take risk. That's what we do. And that's one of the reasons we're one of the first people to point out when a service is unnecessary or ineffective. And we can take a lot of bullets for that, and we will continuously, and the government will too. But in the end, you have to be responsible when you're spending the pool's money. Remember, insurers don't pay for anything. We use your money to pay for something. That's what the pool is, and that's what the government does too. And we have a responsibility to the pool to use that money in a fair, effective manner. And so this is an important issue, and over time it's going to get to be a more important issue as we cover more people. And we're going to have a conversation with ourselves as a society about how to be responsible about the use of services.
Very good point, and I know Kristen and all of the folks on the panel, and I certainly agree with you, Doug. The problem is that some providers don't like being exposed, don't like having their prices and services compared to others. They're not going to like this marketplace, and they definitely don't like this Independent Payment Advisory Board because it does expose who's charging more and giving less. But that's exactly what we need to be doing. Now, here's a question we oftentimes get. It says, all my Canadian cousins have U.S. health care insurance and use services in Seattle, Rochester, and Boston because their system in Canada has long waiting lists for surgery and tests like MRIs. Will this Affordable Care Act have waiting lists? I know the answer, but I'd better let somebody respond.
So the Affordable Care Act relies on private health insurance companies to deliver services. There's no government waiting lists. We're giving consumers the opportunity, many of them for the first time, to purchase private health insurance. And we are extraordinarily optimistic that people are going to have a great consumer experience, and it's like existing private health insurance plans that are out there today.
Thank you.
Short answer is no.
Yes.
I want to tell
Short answer is no.
I want to tell you a quick story about my dad. My dad's 81, and he's a federal retiree. He was rushing home from Florida last winter to get to a doctor's appointment, or he was trying to get out of town to get back here. And I asked him what the appointment was, and he told me it was a colonoscopy. And I said, Dad, you should just relax and stay in Florida. There's no reason for a man who's 81 to be rushing home to have a colonoscopy. It's not recommended. Obviously, he's not going to a gerontologist, which he should be. The bottom line is, after 81, the chances of perforating your colon is pretty high, and it'll do more damage than anything that would be found. So I explained the whole thing thinking, my dad's a smart guy. He's going to agree with me and relax and the whole thing. He says, I'm glad you think I'm going to be dead soon. In other words, you're thinking about inheritance or something. And I laughed. I said, come on, Dad, you know better than this. He rushed home and went to the appointment. So, as a culture, we all have to change how we think about these things. When somebody tells us something, we just take it. And the reality is that's not the best way to think about it. And we're going to have to get more educated as time goes on.
Yeah, and we need to think for ourselves. This provider wanted to make money by giving this 81-year-old man a colonoscopy. Now, clearly, if he's getting a colonoscopy, he hasn't been diagnosed for cancer. He's checking. But the likelihood of getting a perforation in your colon and then getting sepsis and dying as a result of the sepsis is far greater than the likelihood of finding cancer and then dying from that cancer, because it's a very, very slow-growing cancer. So that money should be saved. That service should not be performed. But the provider isn't going to tell the patient that because they want to make the money. So the patient, in this case your father, really ought to listen to his son, but apparently that's not going to happen tomorrow. But good luck with that, Doug. It's good advice. Too bad it wasn't taken. But many doctors are planning on leaving their practice or refusing Medicare patients. What ensures doctor availability and being able to be seen by the doctors within 1 or 2 weeks?
Let me take on the Medicare piece. This comes up periodically. It comes up all the time. Will doctors continue to accept Medicare patients? And as the Congressman knows, every year, or sometimes a couple of times a year, we face the so-called doc fix, where Congress has to raise the allowable payments to doctors under Medicare. As of this point in recent years, doctor participation in Medicare has stayed quite steady. It's actually grown slightly from a little bit less than 90% to a little bit over 90%. And we don't see anything under the Affordable Care Act that would change that. And also, as long as I've got the mic, I don't see anything under the private insurance plans under the Affordable Care Act that would change that at all. I know there are a lot of things being said out there, as there always have been, like when Medicare was originally being opposed because it was supposedly socialized medicine, and there are a lot of things that are going around now that are kind of scare stories. There's just no basis to anything like that. I don't know if any of the other members of the panel wish to address that, but I just don't see anything that would change people's ability to get a doctor's appointment within a reasonable period of time.
We're regulated as private plans to have networks and adequate networks, and that's a state regulation under the Department of Health, and that isn't changing for the plans offered in the exchange. And by the way, those rules also apply to the Medicaid insurance plans. One of the answers to the question of increased capacity is Eduardo's job working with the federally qualified health centers. We have federally qualified health centers all over Virginia. They have the capacity to serve more than 100,000 patients more than they serve today. They're the basis of a number of these networks that are required to be included in the networks. The health systems have grown and have become more inclusive of physicians and are growing their capacity to prepare for the law as well. And we have health systems in every region of Virginia that are making those preparations. So we feel confident that we have what we need to serve the population in a timely fashion.
Okay, so this business of doctors quitting their practice and not seeing Medicare patients because of the Affordable Care Act is a scare tactic. It reflects an ideological opposition to the kind of coverage the Affordable Care Act provides, but it's based upon false information. So it's wrong. It says many doctors are planning on leaving their practice and denying Medicare recipients. Not true. Hepatitis C, 5 million unaware victims. Will the Affordable Care Act keep them from financial ruin?
Absolutely. So one of the millions of people right now are locked out of the health insurance market because they have a pre-existing condition, or priced out of the market where if they don't get coverage from their employer and they don't get coverage from Medicare, they have no way to access affordable health insurance. The fundamental goal of the Affordable Care Act is to change that, to make sure that people have a way to connect to affordable coverage through the marketplace. So people with hepatitis C or any other condition, or healthy people, have a way to connect to affordable health insurance. And again, the health insurance that they're buying, it's comprehensive. It covers those 10 categories of essential health benefits. It provides, even at that basic broad level, it provides meaningful financial protection for people who are who experience an illness or injury, and it really protects folks and is there for them, and they have a way to afford it.
Thank you. Well done, as usual, Tristan. Is it unrealistic to expect a president to walk away from his signature achievement because some members of Congress still oppose it and want to defund it? Yes. The president is not going to walk away from it. And in fact, if there is language on the what's called the continuing resolution to continue to fund the federal government, which my district is only one of the very few districts who even know what a CR is, but it would keep the government funded. But if there is that prohibition to defund the Affordable Care Act, the president will veto it. So he's not going to let this law die, nor is the Senate. So it's going to be law. Even though some people continue to suggest that it won't be, I promise you it will be. Now, I'm on unemployment and can't afford insurance and not eligible for Medicare because of my age. What do I do?
That's what the health insurance marketplace is for. Based on your income, you'll qualify for these tax credits. Your income is depressed right now because you're unemployed. That means the tax credit will cover a significant portion of the premium. Millions of people are going to pay less than $100 a month for health insurance. It's a significant tax credit. People think they can't afford health insurance today, and they're right. Many of them can't. But because of the tax credits that are available in the marketplace, more and more people will be able to afford health insurance. Somebody like the person who asked this question is exactly who the marketplace is designed to serve, and designed to ensure that they have access to affordable health insurance that provides a continuity of care and a continuity of coverage.
Nice going. Thank you. So I trust some people are getting it now. You know, you're going to have insurance available. Even if you had a child or a loved one or yourself had a pre-existing condition and it was too expensive because of the pre-existing condition, you're now going to have it available. It's going to be affordable. If you're elderly, the insurance costs are going to be considerably less. If you're unemployed, if you lose your job, if some catastrophe happens, you're going to have health insurance. Everybody's going to have health insurance, and it's going to be affordable. There's still going to be a lot of people griping about it because they don't like the idea of providing health insurance for everyone. But it's not universal government health care like virtually every other country in the world provides. We're using private health insurance plans. But we're making sure that they're accessible, that they're transparent, that they're affordable, so that everybody can take advantage of health insurance, so that they, and particularly their children and their grandparents, don't suffer because it's not available. In terms of Medicare, as Patrick made clear, it doesn't change. Now, I'm only going to do, we're going to finish up in less than 5 minutes. You stuck with us. It's just about 9 o'clock. Another couple of questions, and then we're going to, and you can ask others afterwards questions that you might have. But for those who are so courteous as to stay, we said it was going to last till 9. We're going to keep our word. So here's a 3-part question, so that way it'll actually be 4 questions before we quit. Will the plans in the market plan have same participating physicians as current insurance plans? Well, that's up to the insurer what plan is offered.
That's right. The networks will be adequate, but they're not going to be exactly the same as every other plan that's out there. One of the things that people are going to trade off is the size of the network choices, the number of choices they have. It doesn't mean that they necessarily are going to have less choices than they want, but they are going to be trading off something. You are in a price competitive product when you're in an exchange. That's the point of the exchange. So that's the idea, is to force some trade-offs. So there will be some differences, and that's why you need to look real carefully when you're looking at your plans. If you have a physician that you like a lot, look at the plans and see which ones they're under. Now, obviously, the plans are competing with one another to make sure that they have the physicians and hospitals in the area in their network so that people can go where they want to go, or else they won't buy their plan. So this is all part of the competitive structure of what's happening, but you do have to ask questions and think it through and get access to information. The provider networks will be available in links on the plan's websites.
And also, we want you to talk to your neighbors, but if your neighbor says, oh, this plan is great, it works for me, you still want to be an educated consumer and look and see what's best for you. So it might be best for Joe lives down the street is not the best for you and your family. So just make sure that when you're looking at the plans, you're looking at them for what meets your needs for your family.
So, you get it. If it was a government-run health care system, you don't have to make those choices. Government makes them for you. On the other hand, if it was completely free enterprise system, which the majority, at least in the House, want, then you're on your own. If you make the wrong decision, tough luck. What we have is a hybrid. We're going to provide as much information available. It's still going to be in the private sector, but the government is going to kind of guide you and regulate the costs so that it's fair, so that it's transparent. And so excessive profits can't be obtained by some insurers who choose to cut corners, whereas other insurers don't. So you're going to be able to choose the best plan within a privately run system, unless you're on Medicare, and then it is a federal plan, and you have less choice. Now, do I need to re-enroll each year? Good question.
So the process there does need to be a redetermination of eligibility every year. The process is pretty straightforward. So the marketplace, healthcare.gov, the marketplace will send you a notice that says, this is the information we have about you, is this correct? You'll review the information that's provided on that notice, indicate any changes in income, if you got a raise, if you changed jobs, indicate any changes in any of the information provided in that notice. By the way, you should be making those changes throughout the year as well, but the notice you get for your redetermination is another opportunity to make those changes, sign it, send it back to the marketplace, and then the marketplace will use that information, redetermine your eligibility, let you know the outcome, and then from there you can just stay in the same qualified health plan and keep paying your premium. So there is a process every year, but it's not nearly as challenging as the initial application process. The marketplace just sends it to you and you sign it and send it back.
And to reiterate, for those who are on Medicare, there's no need to re-enroll every year. There will be an open enrollment period if you choose to re-examine what plans you're in, what supplemental coverage you have, or whether you want to stay with traditional Medicare or go with the Medicare Advantage plan. But if you are happy with what you've got and don't do anything, your coverage would just stay the same.
Very good. Now, what happens if I make more money? How and where do I get insurance?
So the marketplace is still the place for you. If your income is too high for you to qualify for the tax credits, the marketplace is still going to be a great resource for you to find coverage. You're guaranteed that it covers those 10 essential health benefits. It meets these standards for overall comprehensiveness. You may find that your income changes during the year, and so if you lose some income, you'll be able to start getting the benefit of the tax credits. And the other advantage of plans in the marketplace and sort of across the market that's really different from the way it is today is that nobody anywhere can charge you more based on pre-existing conditions, and there's limits on how much they can charge based on age. So even if you're not qualifying for the tax credits, the marketplace is likely to be a more affordable source of comprehensive coverage than the individual market is today.
Very good.
Hey, Jim.
Yeah, Doug.
Let me talk about cheating real quick. People are going to cheat on their income. Some will
Human
say,
nature.
Well, if you're at 80%,
Nobody here or in Alexandria does, but perhaps in
so if you're
other
at
parts.
80% of federal poverty level and you don't qualify for anything because we haven't expanded Medicaid yet, but at 100 you would get access to coverage, you might say that your income's 100. If you get dinged at the end of the year on your taxes, they might, let's say, reach in and take some of your earned income tax credit to make up for the difference. If you said your income was lower and it ended up being higher, they're going to reach in and take it back. So there's an incentive not to cheat. But there's also a limit to the consequences for cheating. And so that's going to be a challenge to administer, and everyone's going to have to figure out how to make it work. A lot of it, though, is intergovernmental transfers, really. And it's where we're reaching in and taking back something that came from someplace else. So it'll be interesting to deal with. And that, look, we haven't figured out every last thing. And if we walk around pretending like we did, we're going to mislead people. There's going to be some challenging things to figure out.
It's a very good point. For example, with young people, if you don't enroll, okay, it's mandatory that you enroll, but what if you don't enroll? What if you don't buy insurance? Even though this whole system is set up on a balance. You need to balance young, healthy people with older and less healthy people so that the average risk is affordable by the insurers. So we need everyone to sign up that this system is going to work. So we mandate it. But, so what if I said the heck with the mandate? Well, then you pay a fine. But that fine, at least initially, is going to be very low. So a lot of young people are essentially going to cheat the system. They're going to pay the little fine and not get insurance, because they know that when they go to a health care provider, they have to get health care. And somebody is likely to subsidize that health care, even though they didn't get insurance. That happens. Over time, we will probably increase that fee, and young people are going to figure out pretty quickly, well, gosh, this isn't much of a fee. I'm going to take the risk, because I know that, certainly, particularly under the Affordable Care Act, if I get really sick or get in a serious motorcycle accident or car accident, whatever, I have to get care anyways. So it's somebody else's problem to figure out how to pay for it if I don't have the means to pay for it. So I'm not going to get insurance. A lot of people are going to do that. It's a, you know, you could call it a failure of the system, or you could just figure that, you know, we decided in order to get this coverage throughout, to get this thing implemented, to avoid, you know, the kind of criticism we were bound to get, we're going to keep these fees very low and hope that people recognize that it'd be a good thing to be involved in what I know is going to be a good thing for this country. Now with that, we're going to, oh, I got one more, because there probably will be a number of small employers that are going to face this. How do I set up plans for my employees? What is SHOP? So you call this number, 1-800-706-7893. They're going to tell you. Or you can call these lovely navigators here and ask them. They'll help you. Or you can call healthcare.gov. They'll help you. You just go to you know, that website, healthcare.gov, or call our office, which some people will do, and I don't really want to suggest it because there's lots of other sources, but we're going to refer you to the people who are really paid and qualified to help you through this. But there will be people to help, even in Virginia. Well, I say that because, you know, there are a whole lot of people, not so much in Northern Virginia, but in other parts of the state, who don't think this is a good idea. I think they're going to find that it was, and that it's going to work, just like Medicare. An awful lot of resistance to Medicare when it was first passed. But now it's a third rail. You can't touch it, you know? So same thing with Social Security. So let's hope this works. If it does work, we're all going to be better off as a society and an economy. I thank all of you for coming, and I particularly thank the panel. You were wonderful. Nice job. Thank you all. Great audience. Appreciate it.